Greetings everyone, my name is Efecan Tatarlar. I am the first author of this research. I am presenting our study on behalf of my team. First of all, thank you for your time to introduce our research. Today I'm going to present you our phantom study. It is actually an evaluation of a novel three-lumen balloon catheter for the potential treatment of intractable limb ischemia. First, let me explain what is critical limb ischemia. Critical limb ischemia is the most severe form of peripheral artery disease, which includes occlusive arterial syndromes, and also failed treatment invariably results in amputation, unfortunately. What are the clinical features? Extremity rest pain, extremity gangrene or ulcers, systolic ankle pressure is below 50 millimeter mercury. Let's dive into some numbers. If you look at the incidence and mortality rates in Western countries, is around 500 to 1,000 per million year, and 150,000 cases per year in the United States, and 120 to 500 major amputations are performed each year per million patients. Post-amputation mortality rates are 40% at 1 year and rising to 80% at 5 years. So what are the treatment options for those patients? Revascularization by endovascular therapy or bypass surgery are the main means of treatment to restore the ankle systolic pressure above 60 millimeter mercury or more. However, for some patients, these methods fail or are not applicable. CLI patients with heavily calcified chronic total occlusions encounter a 20% failure by the standard treatments. Let's talk about our hyperperfusion catheter. The owner of the patent is Emir Yusuf, and he's a medical doctor and also one of the authors of this research. In the picture below, you can see our custom-made catheter that produced in our labs. It was designed and fabricated based on the hyperperfusion catheter design. It's a 9 French 3-lumen balloon catheter. An inflatable balloon is incorporated in between the inflow and outflow lumen holes, as you can see in the picture on the right side of the screen. It is made of medical grade latex. Also, you can see the picture at the right side again. The catheter extrusion or blue colored shaft is made of Pebax. It's a medical grade thermoplastic polymer. Now, I would like to talk about our objective. Basically, the objective of this study is to evaluate this potential treatment option with the hyperperfusion catheter for the CLI patients who are considered primary amputation. The proposed catheter aims to increase ankle systolic pressures to 60 millimeter mercury or more to promote healing, elevate severe pain due to intractable limb ischemia in patients with CLI. Blood pressure in isolated area is increased by extracorporeal pump to a sufficient level until the desired ankle pressure is achieved and sustained for 24 hours. The procedure can be repeated until healing begins and ankle systolic pressure remains above 60 millimeter mercury without any external support. Let me explain to you in detail how it will be applied to a human body. The catheter is inserted to the artery with obstructed outflow, such as common femoral or iliofemoral junction of the affected limb, proximal to the collateral system of the leg by a proper catheter sheath. Afterwards, the compliant balloon is inflated to isolate systemic circulation, and blood from the systemic circulation is drawn from the proximal channel inlets of the catheter and delivered to isolated circulation through the distal channel inlet at a higher pressure by use of an extracorporeal pump. We presume elevating ankle pressure to 60 millimeter mercury or above through collateral vessels for 1 to 4 weeks by using proposed catheter will promote tissue revascularization, adequate healing in the troubled limb area, and the potential development of a new collateral circulation. How do we apply the catheter in our study? So in our study, first we inserted the catheter to the CLI phantom through an 18 French catheter sheath, then inflate the compliant balloon with a saline water. Afterwards, we turn on the extracorporeal pump, that connected to the catheter, and healing process starts. In our case, data acquisition starts, of course. Here on this slide, you can see how the experiment is set up. It is the CLI phantom model. To simulate the peripheral arteries of related anatomy, the model was constructed by using a modified hemodialysis circuit, a hemodialysis pump, and a tube set used in cardiopulmonary bypass surgery. Two mini C-clamps were used to simulate peripheral and occlusion resistance. These can be adjusted manually, so the systemic and ankle pressure levels can be set to simulate the common criteria of patients with CLI. An extracorporeal peristaltic pump was used to simulate systemic blood circulation. A second extracorporeal peristaltic pump was connected to custom-made catheter. Blood mimicking fluid was prepared to simulate the dynamic viscosity of blood. To measure the dynamic pressure, three invasive blood pressure transducers were used. The first transducer was placed at the output of primary peristaltic pump, which represents systemic pressure. The second transducer was placed to measure assisted circulation pressure right below the inflated compliant balloon. The third transducer was placed distal to the simulated collateral circulation, which represents the ankle pressure. A custom-made electrical circuit design and a computer used to do data acquisition. So here are results. Each graphic represents a recorded sample of 5 trials of each experiment. Blue curves are represent systemic pressure, while reds are distal pressure, or let's say ankle pressure. So in each experiment, the CLI phantom model without the catheter was set up, while peristaltic pump of the systemic circulation was working with a flow rate around 148 milliliter per minute. The systolic pressure of the systemic circulation set to 120 millimeter mercury. 5 different distal pressure settings at 32, 40, 45, 50, and 55 millimeter mercury were tested by adjusting the pressure with mini C clamps to simulate ankle systolic pressure. And also the last experiment was to test the compliant balloon was working properly when it's inflated. It was inflated. So let's see the results. As a reminder, this setup is designed to simulate actual compromised arterial circulation. Table 1 shows the mean standard deviation and coefficient of variation, or CV, let's say, of the recorded systolic pressures for each adjusted ankle pressure value. The shown values are average of the 5 recorded sets. The coefficient of variation is defined as standard deviation divided by the mean, which expressed as a percentage, as you may know. The CV provides general feeling about the performance of the repeat experiment. If it is 5% or less, that generally gives us a feeling of good method performance. Whereas if they are like 10% or higher, it sounds bad. This test is especially useful for checking the consistency of repeated chromatography results. It can equally well apply to any repeating experiment where consistency is expected. As in our experiment, and except when the mean of the experiment approaches 0, when by definition the test loses its meaning because it's divided by 0. In all experiments, the values of the coefficient of variation were less than 5%, as you see on the table. All experiments can be evaluated as having a good method of performance. This evaluation is not valid for ankle pressure values after balloon occlusion. It's a desired outcome, actually. Let's see our evaluation of the performance of our catheter. The recorded pressure curves of the experiment with assisted circulation by the custom-made catheter. Each graphic represents a recorded sample of 5 trials of each experiment. Blue curves represent systemic pressure, black ones are proximal pressure, and red ones are distal, or let's say ankle pressure. If you focus on the red line or ankle pressure, let's say, you will notice that they are approximately 80 millimeter mercury or above, while the blue curves are stable. So let's see the numbers at the table. The table 2 shows results of mean, standard deviation, and coefficient of variation of the recorded systolic pressures for each adjusted ankle pressure value with the custom-made catheter, of course. 5 trials were performed for each pressure value. The shown values are average of 5 recorded sets. In Table 2, the results have shown that the systolic pressure values that were measured between the isolated arterial branch and troubled area can be maintained above 270 millimeter mercury. The systolic pressure values distal to the occluded part, which corresponds to ankle pressure, can be elevated above 80 millimeter mercury. The results have proven that the objective of maintaining high pressure around 280 millimeter mercury or more locally in the isolated arterial branch distal to the occlusive balloon to elevate ankle pressures above 60 millimeter mercury by using the custom-made catheter can be successfully achieved. Increasing the pressure to around 280 millimeter mercury or above has no effect on the systemic circulation pressure. Again, in all experiments, the values of coefficient of variation were less than 5%. All experiments can be evaluated as having good method performance. So let's talk about the conclusion. The results have shown that the ankle systolic pressure values can be elevated up to 80 millimeter mercury when the systolic pressure in isolated arterial branch proximal to the occluded part can be maintained above 270 millimeter mercury. Hyperperfusion catheter design can deliver enough blood mimicking fluid to peripheral circulation by using an extracorporeal peristaltic pump without affecting any change in the systemic circulation. In conclusion, this phantom study results have shown that the proposed invasive treatment option using the custom designed catheter can provide the desired blood pressure increase in the occluded region and can be considered a new treatment option for patients with CLI. In the future, additional therapeutic advantages by using hyperperfusion catheter may occur. What are those advantages? Administration of vasodilators and thrombolytic medication in small doses to compromise arterial branches would facilitate rapid development of collateral circulation, resulting in higher distal tissue perfusion. Administration of effective antibiotics in smaller doses to arterial branches will result in a higher tissue concentration. Higher doses will not be necessary for systemic administration. Non-atherosclerotic inflammatory occlusions and immunovascular diseases may have higher healing rates with hyperperfusion. Conventional bypass and endovascular surgery have little or no beneficial effect on these groups of patients. In difficult endovascular procedures where flow is low after the procedure, hyperperfusion for 24 or 36 hours may prevent early reocclusion. Again, in difficult endovascular procedures where extensive endothelial damage occurs or extraluminal passage may be necessitated, hyperperfusion for 24 or 36 hours may prevent early reocclusion. In isolated extremity malignancies, hyperperfusion catheter can provide acute chemotherapy by isolating the desired arterial segment. In failing free flaps and failing member replantation, hyperperfusion may save the flap or the grafted member. So these are the following references. And thank you for your time. Thank you.